Hi, my name's Jason Weger, and we are lucky to be here with Chris today. Chris is a clinical pharmacist at Norman Regional Hospital, and we are going to talk about medication safety and medication administration and the role of a clinical pharmacist in all things medicine. So, Chris, do you mind introducing yourself?
No, not at all. Thanks for thinking of me, Jason, when you were deciding to do this podcast. I feel very honored that you asked me to do it. So I'm Christopher Brown. Actually started at Norman Regional Hospital back in 2010 as a pharmacy tech, and then I stayed on working as an intern throughout pharmacy school. Went to OU for pharmacy school, did the residency program here after pharmacy school, which is like a 1-year postgraduate residency training program so that you can work on the clinical side of things as a pharmacist. At that point in time, I kind of filled in all over the health system, working primarily like med surge, progressive care, cardiac care units, until about 5 years ago when I took on more of a cardiology role. And around that time, I also got, after working in cardiology for about a year, I got the residency program director position for the pharmacy residency program at Norman Regional. And I've been practicing ever since. My primary focus is cardiology. And so probably a lot of the questions that you'll ask me today might take a bit of a cardio related swing to them. But if I'm going down the wrong path, just redirect me.
No, we love
Whatever you.
cardiac. And our nursing students, cardiac's one of their favorite topics too. So that'll be very helpful. So yeah, it's an honor to have you here. One of the reasons I wanted to interview you in particular is because you're such a great resource for the hospital and for nurses. I've worked with you in the emergency room. That's the first time I've ever worked with a pharmacist in the emergency room, and that's just one of the best ideas I've ever seen before. And you're just a good resources, and I know that the clinical pharmacists at Norman Regional definitely save lives, mainly due for medication safety and being a resource for the nurses. So thank you.
Thank you. And I feel like pharmacists are really utilized really well in the emergency departments. We're great up on the floors as well too, but like we are happy, willing, and like want to work alongside the nurses and help improve patient outcomes wherever we can.
Okay. Yeah, thank you. Okay, well, let's get started with the first question. What role do you think the registered nurse plays in medication safety and just keeping patients safe when they're administering medications?
Yeah, honestly, I think they're probably the most crucial component to keeping a patient safe when it comes to medication administration, because I really think of them as like at least the last line of defense before a medication is actually administered to a patient. So in general, the provider is going to order a medication. Hopefully it'll come across a pharmacist, and the pharmacist will be able to verify the medication, look for a variety of different problems that they might need to reach out to the provider about, and hopefully take care of some issues before it makes it to the nurse to administer it to the patient. Then if it passes those two levels, it's really up to the nurse to be questioning at that point in time. And I can't tell you how many times working as a clinical pharmacist up on a unit, a curious nurse will come to me just having a question about one of the medications they're about to administer or that needs to be administered, and we'll find a problem with it. We won't give it. We'll contact the provider, we'll get it changed, or do a variety of other different things. And those types of things happen probably more often than you'd like to think.
Yeah. I'm glad you used that term, last line of defense, because we actually teach that term in nursing school. And we try to tell our students that when you're at the patient's bedside and you're about to give the medicine, that it's typically just you. There's no one looking over your shoulder. There's not a pharmacist standing there. There's not a physician standing there. So you are the only one that's going to be given that medication. So yeah, thank you.
You're required to administer it. You're required to educate the patients and or the caregivers on proper administration of medications. You have to monitor them for side effects, adverse drug reactions. Lots of things are on nurses' shoulders.
Yeah,
And you really are the eyes and ears of the physicians and the pharmacists too, because you're going to have your eyes on the patient the most throughout the day. So
yeah.
vitally important in medication safety for nurses.
And just a little advice to our new graduates that are going to be working and giving medications here soon. Before you give a medication and before you go into the room, if you don't know much about it, then a clinical pharmacist would be a good person to ask, or at least look it up in our drug book or on our EMR. The worst thing that you can do is go give a medication that you don't know what it's going to do. But also, the patient and the family members may ask you, why are you giving this medication? And you better have an answer.
Excellent advice.
Yeah.
Sure, for sure.
So you kind of talked about it, but what does a clinical pharmacist do? And for our nurses that are going to be entering the field and maybe working at your hospital, how would they contact you and how does that process work?
Yeah, so at Norton Regional, we have basically two different types of pharmacists. We have like the clinical pharmacy specialist who's up on the floors on the units of the patients that they're providing care for. And then we have what's known as like distributive pharmacists who work down in the main pharmacy and do more like order verification, IV admixture, actually preparing the medications downstairs and sending them upstairs. So as a clinical pharmacy specialist up on the floor, the main thing that I'm doing is I'm responsible for medication orders on all the patients that are on our floors. We'll be consulted by the physicians to provide recommendations for antibiotics or dose certain medications like antibiotics or anticoagulants. We'll perform antimicrobial stewardship. We'll monitor anticoagulation on the floor and do a variety of different things. We have an office on the floor, and if you ever have a question, we want you to come by and look at it too. We want to help you in any way that we can, especially on like high risk, high alert types of medications. There'll often be times where, you know, you'll want to start a drip or titrate a drip, and I'm happy to come in there and help you get it set up, put it on the pump, make sure everything gets titrated appropriately, and provide education at the same time too. Like like you said earlier, if you are about to administer a med or you want to know something extra about it, come find us and we'll talk to you about it. You know?
Yeah. Yeah, that's a great resource to have. And actually, the hospital is fortunate because some places don't have the clinical pharmacist at their very close to them.
Right. And some hospitals only have like one or two, and they're kind of stationed down in the main pharmacy, and they're responsible for all the patients in the hospital. And so you don't really get to see them a lot. They're kind of working behind the scenes, but we're up on the floors, and we're trying to help in whatever capacity. When we came to the floors, we didn't come to the floors in order to be like more efficient or productive. We came to the floors like for patient safety and outcomes.
Yeah,
So
for sure.
utilize us as much as you can.
Okay. So can you tell us about a time that you've seen a registered nurse make a medication error and what was the outcome? And, you know, we have all these systems in place to prevent that. Can you tell us what system broke down or tends to break down when we have medication errors?
Yeah, absolutely. The vast majority of the time, we're going to go through that process that I talked about earlier, where the provider orders it, a pharmacist verifies it, checks to make sure that it's okay, and then it's administered by the nurse. There are ways around that system, and like one of the biggest med errors that I think of that happened probably like 4 or 5 years ago at this point in time, a physician was coming by to a patient's room in the ICU, and they had given the nurse a verbal order for like some Versed. They were going to do like a bedside procedure. I think they were putting in like a chest tube, and they wanted to give some Versed. So she asked her colleague to go get the Versed out of the Pyxis. They go into the Pyxis, type in VER, pull out the first thing that came up, and then gave it to the patient. It had already happened, and she was telling me, hey, can you put in an order for Versed 2.5 milligrams by this provider? And I was like, yeah, sure, I'll just, expect to see the written order here in a minute. She's like, it's already happened, it's already been done. I go to type in Versed 2.5 milligrams, and I was like, I was kind of curious because I was like, 2.5 milligrams is kind of a weird dose for Versed, Normally it's like 2 milligrams. It comes in like 2 milligrams or 5 milligram vials. And so I called her back to see if like maybe I had misheard her or something. Like she looked at the vial and it was verapamil. So her friend had gone to the Pyxis, typed in VER, chose the first thing on the list, and instead of Versed, it was verapamil. So that's one of the things that can happen. He had drawn it up for her, given her the syringe, and then she gave him the medication. So she gave some verapamil pre-procedure before a chest tube. Patient's not going to be adequately sedated, going to need to monitor blood pressure and heart rate for a short period of time. And then, one of the things that's nice about giving a sedative like Versed is you generally get a little bit of retrograde amnesia, so you're not going to remember the painful experience that happened. And so all of those things are kind of what's going to be going on. And in that area, you're kind of bypassing the pharmacist too. Physicians come into the floor, they want a medication pretty quickly. You're going and grabbing it out on override.
Yeah. So I've seen this happen, and I think it always comes down to a communication breakdown, usually.
Absolutely.
The nurse will feel terrible about it, but the nurse at that point is trying to do what's good for the patient, but also trying to make the physician not stand around and wait. So there's a sense of urgency, and when there's a sense of urgency, that's when we make a mistake. So
yeah. So be careful. Again, like come find me. Like if a provider comes to you and says that they want some Versed, you can tell me, I'll put it in right away. I'll probably even go get it for you myself. Especially if it's like not a non-controlled substance, but a lot of times, working in the ER too, like if a patient comes in and I get a verbal order from a physician, I'll go grab it myself out of the Pyxis, which that's not going to be available to all nurses wherever you wind up, but just make sure that you're being careful and you're verifying the medications that are given to you.
So if a nurse does make a mistake, what do they do?
Yeah, so if you make an error, we really encourage like self-reporting, self-monitoring. There'll be times too where we'll discover an error and we'll report it. But what we do is we have like a variancing system where we'll go in, we put in like as many objective facts that have happened about the error, and then if it needs to be looked into further, we'll take like a systematic approach, and like risk will be involved. And there's a variety of questions that they try to answer when the error occurs. So it's like, what happened? What normally happens? What do our policies and procedures require? Why did it happen? How are we managing the risk? What's the root cause? And then what action was taken afterwards? So we try to go through those steps to make sure we understand why it happened and try to prevent it from happening. If you want an example, I could kind of give you an example of one that's happened not too long ago. So there's a heparin drip. It needed to be titrated based on the protocol, and it wasn't decreased appropriately. So that's like what happened. What normally happens is when the anti-10A level was that high, they'd hold it for like an hour and then decrease by like 5 units per kilogram per hour. They didn't do the 1 hour hold in this situation, so that's why the variance got put in. Our policies and procedures would dictate that they follow the protocol, and so that's what procedure requires. Why did it happen? When the nurse was looking at Meditech, which is our electronic medical record, they just didn't see the hold times 1 hour. They just saw the decrease by 5 units per kilograms per hour. So how did we manage that risk? Went over the protocol with them, did a little one-on-one education with the nurse and the charge nurse too, because at our health system, we require heparin to be signed off by 2 different people, the nurse and the charge nurse. What was the root cause? Here's where we use like a just culture approach, where we try to decide like what actually happened. Was it human error? Was it at-risk behavior? Was it reckless behavior? Or was there like some sort of harm that was, a purpose to cause harm or knowingly harming someone? If it's just human error, we try to accept that, educate, move on. If it's at-risk behavior, we coach. And if it's reckless behavior or knowingly harming someone, there's going to be disciplinary action involved.
Yeah.
All of it, again, is to try to prevent errors from happening in the future and to learn and grow.
Yeah. Thank you. I'm glad you talked about heparin, because that's going to be our next topic. Is we start teaching about high alert medications very early on in our nursing program. Thinking about like heparin and insulin. What makes those high risk, and is there anything special the nurse should do if they're going to be given a high alert medication?
Yeah, I thought about this a little bit, because I think that you can go down a couple different paths, but like medications that are like high alert medications, they're going to have a tendency to cause harm if given incorrectly, and so you really want to be thinking, taking your time, slowing down when giving those types of medications. Like insulin, I could tell a story. Like I was interviewing a patient a couple years ago, and I was asking her about her like home insulin dose, because it looked like it had been entered in the med rec incorrectly, and I just wanted to make sure. And she had told me a story about how back in like the 1970s, her sister had been diagnosed with type 1 diabetes, and she was taking like a cross-country trip on a train to come back home to see her sister. She lived out in California. Her sister lived in Oklahoma. And she had just been given a vial of insulin. And she didn't want to wake up and check her blood sugar frequently. And so she subcutaneously injected the entire vial of insulin prior to going to sleep on this train ride. And unfortunately, as a complication of doing that, she passed away. She didn't make it. And so, that's just one of the reasons why insulin is a high alert medication, because you can have tragic outcomes if it's given inappropriately. Heparin's the same thing. You need to worry about bleed risk. It takes a lot of monitoring, and it's kind of complicated to do too. Now with nurses who are just coming out of nursing school, I honestly think that they'll probably be a little bit more likely to slow down, make sure what they're doing is appropriate. I think the issues come when you've done it like 1,000 times, like the person whose parachute doesn't open is the person who's, parachuted, skydived 1,000 times, and they just didn't check their pack that one time appropriately. So when it comes to these types of high-risk medications, make sure that you slow down, like no matter how many times you've done them before, to make sure that you get it correctly. This isn't one of those things that you can do on automatic,
Yeah, thank you. So since we're talking about, high alert medications, one of the more complicated medications that I've had to give as a nurse is TPA that we give for ischemic strokes. I think the
Hmm.
process has gotten a little bit easier depending on the medication that you give. It used to be a nightmare to have to mix and to make, and the calculations were confusing. And yeah, so can you talk about why we give TPA and what we're giving now instead?
Yeah, sure. So the main indication that we're giving TPA for is typically for like an acute ischemic stroke. And they say time is brain, right? So it is a very time-sensitive medication. When the patient presents to the hospital, and they need to be within like a 4.5 hour window of having symptom onset of a stroke, you want to check their brain to make sure that it's not bleeding. So you're going to go straight to CT. And then if you use alteplase, which is what's like FDA approved, you're right, it's a very complicated process where you have this 100 milligram vial, but the maximum dose is 90 milligrams. So there's always going to be some waste involved. And so at bedside, you're generally reconstituting it, pulling up a bolus, administering that bolus over a minute, wasting a certain proportion of it because it's a weight-based dose as well, and then infusing the rest of it over the course of the next hour. On top of that, you need to monitor their blood pressure. You can't even give this medication if their blood pressure is like greater than 185 over 110, right? And so maybe even before giving the alteplase, you got to get their blood pressure down. While you're giving it, you have to monitor their vital signs like every 15 minutes for the first several hours, and like every 30 minutes for several hours after that. It's frequent monitoring, looking to see if the patient's like decompensating at all, because the biggest risk with giving this medication is like a hemorrhagic conversion of their ischemic stroke. So that's what you're kind of looking out for. We here at Norman Regional, we moved over to tenecteplase probably a little bit over a year ago. It doesn't have FDA approval for use in acute ischemic strokes, but it's much easier to administer the medication. You can give an IV push over a few seconds, and then you don't have to worry about the other bolus or the infusion and things like that. You're still going to have the same monitoring, but the administration is much easier. Does that answer your question? I don't want to get too technical into it.
No, that definitely answers and definitely gives a background on what we used to give as TPA, and a much easier process now. So yeah. So for our nurses that are in their critical care course right now, well, I think one of the things that they struggle with is vasopressors, just because there's many
Mm-hmm.
different types, when to give them, um, how are they chosen? Can you talk about in the ICU setting currently, what's the top vasopressor they're going to be given once they graduate, and what would be the parameters to do it, and how would they administer it?
Yes, the primary vasopressor that's generally going to be given is going to be norepinephrine or Levocet. So norepinephrine is a drug of choice for sepsis. It's often used in patients with cardiogenic shock as well, but for whatever reason, that's the medication that's used. It's the medication that has the most experience behind it. It's also going to be the primary catecholamine that's circulating around in our systems at any given time. So that's probably why they go with it. Now, they're all pretty similar, and they might be used for a variety of different reasons. But you got norepinephrine. It's a vasopressor, so it's going to increase your blood pressure. It does that primarily by working on beta and alpha receptors. So it's going to constrict your blood vessels. That's one of the ways that it's going to increase your blood pressure. Also going to increase your heart rate and the contractility of your heart through those beta receptors. While you're doing that, you're going to be titrating it every 3 to 5 minutes based on their blood pressure. Generally, either a systolic of 90 millimeters per minute is what you're going for, or a MAP greater than or equal to 65. When I've been in the ER and we're starting it at like 0.05 units per kilogram per minute, a lot of times we'll titrate it a little bit quicker and then kind of bump back off a little bit quicker too if we need to, if the blood pressure is really low. So we don't technically follow it exactly by the book. We just kind of do it based on experience. I don't know. Maybe this is a bad answer here.
Well, it's the ER, so it's a different animal. So
yeah. One of the first times I was working down in the ER, we had a patient. They were septic. We were getting norepinephrine going, and I was working with a seasoned nurse. So this is like one of my first times in the ER as a pharmacist. Seasoned nurse, been working in the ER for like at least 30 years. Start the norepi. I'm like setting a timer on my watch so that I can come and check, every few minutes to see if we need to titrate it up. And like first titration, he bumps it up like 4 times what we would normally do, and then their blood pressure came up, and then like we backed off pretty much just as quickly too, because their blood pressure came up to above where we would have needed it, and so we backed back down really quickly. But in his experience, he had seen so many different patients working on those little minute titrations that he was like, I get the blood pressure under control as quickly as possible, and then I back off on the backside, which now, again, this is like kind of off the books, so I don't know if we should be talking about it or not. But, like one of the things that you're at risk for with the hypotension is, end organ damage. That's what you're trying to prevent. Like we're trying to give your heart perfusion, we're trying to give your kidneys, your lungs, your brain perfusion. And the longer that you go hypotensive, the more at risk you are for, some adverse effects from low blood pressure.
Awesome. Thank you. So
should we redo that question?
I think it was, I think it was fine. I think it was great.
Okay. Edit out this little part here then, I guess. Now, do you want me to discuss other vasopressors too?
No, I think that one's fine.
Okay. So I will say, like for phenylephrine, it's mainly an alpha agonist, and so you're not going to get the effects on the heart rate with phenylephrine. You're going to get the peripheral vasoconstriction. That's how it's going to increase your blood pressure, but because you don't have the effects on the heart, a lot of times they'll use phenylephrine when you're getting tachyarrhythmias from like the norepinephrine.
Yeah.
So your heart rate's getting too high on the norepi or epi, they'll switch over to the phenylephrine because it's going to take out that beta agonism going on.
All right. Thank you.
Mm-hmm.
So for our nurses that are about to graduate here in just a couple of months, do you have a message for them?
Practice makes the master. I will say, like, these days it's easy to go into automatic mode. I kind of referred to it earlier, but like how many times have you gotten in your car, driven to your destination, you arrive at the destination, and you get out and you're like, wow, I was lost in thought that entire time. I don't even remember coming here, When you're taking care of patients, it can probably get easy to go into that automatic mode after you've been practicing for a while and you get comfortable with what you're doing. But for those high risk, high alert medications, and in other certain scenarios, make sure you stop, slow down, and take the time to make sure you're not in that automatic mode when you're doing a variety of things like administering a heparin drip or titrating a vasopressor or something.
Okay. Thank you. Okay. Finally, you're obviously a very smart guy. You went to pharmacy school and you probably know a lot of chemistry and math. physics. We'd like to give you an opportunity to nerd out, if you will, and tell us about your favorite med or your favorite process or anything that you just love that our nursing students could learn from.
Well, thank you. And that's not entirely true. I don't really see myself as a super smart individual. I feel like I'm determined and perseverant, and I think that those two qualities have helped me in life. And I thought about this because I'm like, I'm a pharmacist. I should probably have favorite medicine or something like maybe magnesium, maybe a statin or something like that. But like what I really truly like is lifestyle modification. The vast majority of patients wouldn't need to be on medications if they ate better and took care of their bodies a little bit better. So, in almost all the guidelines that you're going to read about any type of chronic disease state, the first thing that you want to do and implement in a patient is lifestyle modifications, like regular exercise, eating a healthier diet. If you do those things, a lot of times you can reverse the course of chronic disease states. And I feel like as a pharmacist, like we should really be big advocates for pushing lifestyle modifications and non-pharmacological treatment where appropriate,
Yeah. Thank you. Well, we're honored to have you, and we want to thank you for your time. I guarantee our nursing students are going to learn a lot from this conversation. I do want to say if if our graduates end up working at Norman Regional, Chris has the best class that he teaches in advanced pharmacology. It's an all-day long class. I've taken it. A lot of people have, and it's amazing. So thank you for teaching that class. Our nurses really need it and they love it. So thank you for being here.
Jason, it was an absolute honor and privilege to be here. I really appreciate you thinking of me and reaching out to do this with you. So thank you very much. And I hope that this was helpful.
All right.
Reach out if you need anything else, okay?
All right. Thank you.